Today I'd like to talk about cholestasis management in pediatric patients. So cholestasis means decreased bile flow. Most people think of cholestasis as being an elevated bilirubin. It can actually occur with a normal bilirubin. Usually it has an elevated bilirubin, but not always. Think about it this way. If you had a stream with water in it, the water is the bile flow. And bilirubin is just the leaves that fall off the trees on top of it. And if you have a lot of water, you may not see all that many leaves. If there isn't much bile flow, you may or may not get a whole bunch of leaves in the stream bed, depending on what else is going on. So they usually go together, but not necessarily. And we need to think of them as two different mechanisms. So bile, why do we need it? Well, we need it to absorb fat. We need it to absorb vitamins. We need it to carry away waste from the liver. So things like cholesterol or drug metabolites are carried away in the bile. And it also carries bilirubin out of the body. So what goes wrong if you don't have it? The most obvious thing in pediatrics is kids don't grow very well. They just don't grow. They can't absorb their fats, and they tend to fall off the curve. In some diseases like Alagille's, where they have really high levels of cholesterol because they can't excrete it down their bile ducts, they may get xanthomas and cholesterol deposits on their skin. Back a long time ago, before we had good sources of vitamin K, many of these babies had head bleeds because they had fragile blood vessels, and they can also get rickets. So what do we do to manage it? Most of it is nutrition. Nutrition, nutrition, nutrition. We also need to make sure that they have vitamin supplementation. We do everything we can to modulate their disease and screen for complications. So we give them lots of calories. Sometimes these kids need 150 or 180 calories per kilo per day. Sometimes we have to use NG tubes to get that in because they just can't take enough in. They get fat-soluble vitamin deficient, and we need to use high doses of a water-soluble form. And then we sometimes have to give them MCT oil or medium chain triglycerides because that is a form of fat you can absorb without bile. Sometimes we can modify the disease, sometimes giving urso, which is a bile acid that promotes water flow into the bile, can help in some diseases like progressive familial intrahepatic cholestasis, where the bile acids tend to be toxic. We do biliary diversion, either diverting the bile acids into the colon or out a conduit from the gallbladder to a stoma. Some of these kids need transplant, and we often need to treat their itching because it is very problematic for these kids. It prevents them from sleeping, it prevents them from learning in school. They can get scarred skin and infections from all the scratching. And then we also screen for complications. Bile acids are toxic to the liver cells, so they can develop inflammation and fibrosis, as well as portal hypertension. cholestatic diseases have a higher rate of hepatocellular carcinoma. We need to make sure that they don't have decreased synthetic function, either from lack of vitamin K or from declining liver function. We need to make sure these kids grow and that we maintain their vitamin levels. So it gets pretty complicated, and it's one of those things where you really just need to pay attention to details.